Hello and welcome to India Speak, the Center for Policy Research's podcast series. This is our special series on India and the pandemic. I'm Yamini Aiyar, and today I'm joined by Dr. Abhijit Chowdhury of the Liver Foundation in West Bengal to talk about the impact of the pandemic in rural India, and more specifically to try and understand both how the pandemic has unfolded, what needs to be done in terms of policies to prepare the health system to respond to the pandemic-specific health needs, as well as the overall health needs of rural India. And last but not least, what will it take to vaccinate rural India? Abhijit Chowdhury, it's an absolute privilege for us to have you join us today. Thank you very much for making the time. Can we start the conversation by just hearing from you about your experiences of how COVID now is unfolding as it's traveling from cities into rural India? What is the nature of the disease as it's moving into the hinterlands? How are people responding? What are the ways in which people are accessing the health system? We don't hear enough, certainly not in our rarefied urban circles, about what the realities look like outside of our cities.
Pleasure, Yamini and CPR. I'm privileged to be here today to talk to you and on an issue which really we don't talk that often as possibly is needed. So it's like, in villages, people have got many barriers which have possibly not allowed them to make them access to available care that was available. If I start with the number one barrier had been, the very important, which is not really, it's a subjective barrier, but very important, is the cultural barrier. Because, there is tremendous amount of stigma and fear even today existing everywhere in India, but rural India, a bit enlightened India could get past this with a lot of enrichment of our cultural elements through a lot of endeavors that have gone on. But rural India is still very much submerged in the cultural factors, particularly stigma. Even today, I can tell you about West Bengal, febrile unwell-being, which if we talk of as a beginning point for picking up people with potential COVID infected, febrile unwell-being are still not coming to focus because people are frightened that if I am diagnosed to be COVID, people would look at me with a different eye. I may still get isolated in my community. I may still not be able to, have access to amenities in life that are very important for them because they all live in, villages and mostly they are rural poor or lower middle class. If I say they live in very sort of vulnerable economically and socially, and any amount of push down the social ladder for them, be in terms of access to food, be in terms of access to other amenities within the village or other accesses would mean quite a lot for them. So to be precise, they are still very frightened and they are shy to get tested to have COVID. So that's one of the barriers. So cultural barrier and fear of COVID that was tremendous during the first wave, but still existing in the second wave. Let me tell you a story in a village in Birbhum in West Bengal where we work very closely. So the other day over this weekend, I went to that village because I heard that there are many people who are infected with COVID. Fever is in almost every household. So I went and told them that why you're not getting tested? We will arrange testing for them in liaison with the district health authorities or the block health authorities. They told, no, our fever is, this is like a normal fever. It's not COVID. So, this denial or I should say complacency is killing complacency. We have gone through two very important bad things. One is complacency, that our situation is not as bad. We are doing fair, we are doing good, we are going to be through with COVID soon. And the villagers also have got hold of that. It's not bad. You need to get your people secure, or feeling of security you need to give to your people. But being untruthful of the circumstances and not placing the true situation in the correct perspective is possibly not the right thing to do with a public health emergency. And we possibly has done, and that has gone deep into the village level also, because out of complacency, what has also grown is denial. So people are in a tremendous denial, even in urban areas, but more in rural areas. Rural people are in tremendous denial to agree to the fact that everybody can have COVID. Like at Liver Foundation and our brother organization named COVID Care Network, we have been telling everybody, any forum, any media forum or any other forum, that please, 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 right now it's COVID times. Any amount of fever, sore throat, unwell-being in you should foster a feeling in you to get tested or to have access to healthcare. But the reverse had been happening. People had been telling us during the phase when first wave was transitioning to the second wave, this was even more widespread, that these people are spreading a fear of COVID with ulterior motive. All these had been in public psyche, and village people, because they are perennially insecure out of many social issues, because of many social factors, because COVID had been equated with death. And we had been seeing so many deaths in everywhere, COVID, infected and dead. So nothing, no, rainbow in between. So COVID had been equated with death, and rural people used to think that if I get COVID, if my fever is COVID, I'm going to be dumped into a hospital where I may get COVID even if I don't have, and my fever is not COVID. So this amount of denial and fear is tremendous in them.
Let me just stop you there, because I think you bring up a really important issue that also connects with how we should be thinking about COVID treatment. The fear of being left isolated in the hospital, which is not just limited to a rural fear, but it's a fear across urban and rural areas. And one of the challenges that we faced in cities like Delhi, for instance, which are just emerging out of the surge, is that, there was because we had not actually put in any treatment preparedness for triaging, and also very importantly, for being able to give people the kind of home care that was required. You ended up with people waiting too late at some level to get treated, and then rushing to hospitals in a way that potentially, this is all a matter of speculation since we don't have good data, but anecdotally, people reaching the hospitals either too late or getting exhausted because they got to hospitals when they didn't need to and their condition deteriorating. So there was one of the learnings, I think, from the experience in cities, and if you compare Delhi with, say, Bombay, was that we didn't pay enough attention to ensuring good access to home care treatment, access to medicines, etc. And from what you're saying, perhaps this is a big thing that we need to be taking into account as we think about what are the kinds of policy inputs we need to put in for strengthening treatment in rural areas. Should our focus be on trying to ensure that people get access to care in their homes so they don't have to rush to hospital? And will that also help on the sort of denial issue that you are talking about?
Yeah, I mean, very important aspect of COVID perspective you have brought out. But let me put forth out here for everybody that, the only medicine that you need to combat COVID is oxygen and steroids, and nothing more than that. But if you think in terms of access to home care in the rural areas, important thing could have been we got more prepared to identify the potentially bad COVID-infected people who demanded hospitalization. We have got a tremendous network of ASHA workers across the country. We have got, these Anganwadi workers also. We have got many other community-based health workers, but possibly, that's why I raised the term complacent. We were so complacent during, say, November, December, or January around that, we have won the COVID war, that we really did not impart sufficient training or knowledge in them, or, get them geared up to rise up to the circumstances so that they could make more home visits, pick up those people using pulse oximeters and all this. We did. I'm not telling that the country did not do. The country did more on papers than on grounds. That's unfortunate. Again, I emphasize. If you look for data in the system, you will get many data. This many ASHAs were trained, this many, things were done. But unfortunately, we have learned the very, uncanny way of playing with data. And rather than being ground savvy, but I am telling you the information from the grounds, the villages were really unprepared, and we possibly could have used more resources from within the villages to pick up those people. You talked of home care. The important element of home care is to see 80% of people with COVID are not going to land up with bad things. You can keep them at home, but you need to reassure them that you're not going to die, because panic is a part of pandemic. So everybody, whenever they get COVID, start thinking that I may die. So you have to tell them. You have to tell them reassuringly and with emphasis that you have to die. So you have to have a workforce. You haven't got the workforce in the village level. But unfortunately, we have got a cadre-based system. So we depend on the ASHA as the all-purpose, machinery. And we have failed to pick up groups like the women self-help groups, which I always consider as a multi-purpose, multi-dimensional force, which the country's policymakers somehow feel like, only people geared up for economic activities. But no, let me tell you, we work with them, and I have found them tremendously potential. They can be used for, all these health-related activities, educational activities at the village level, but that was not done. So integration at the village level of the existing forces and the informal healthcare workers all across the country. We have got, many such informal healthcare workers, very suboptimally, trained. They don't have much of a scientific knowledge. They keep on doing bad things which come to focus. But the best part of them is that they are by the side of the people when nobody else is there by the side of the people deep into the villages. So they are candles in darkness. And we did some work in West Bengal, and that was impact assessed by Dr. Abhijit Banerjee and Jishnu Das, and that, after that West Bengal government had made that a policy, but that's in West Bengal only. But elsewhere in the country also, wherever there is, impaired development, I'm not telling the term called lack of development. If I call it impaired development, the more the lamp of development has reached, the more the area, you get more such informal healthcare providers. So informal healthcare providers, women self-help groups, ASHA workers, the Anganwadi workers, we could have created a tremendous village health guard or village well-being guard sort of circumstances, which is not always incentives driven. It's like, motivated to keep the health sanctity or well-being sanctity or welfare sanctity of my village. People, villagers are much more non-incentive driven than we consider them to be. That's my perception, having been a villager myself and having worked with the village health workers for long. So we consider that unless we pay them, they won't work. No, it's not. And I have seen that during the COVID era, many such village health workers, they got self-motivated, structured themselves for home care delivery, and informal healthcare workers. They did wonders, I'm telling you. But that has not come to focus. We could have trained them up in a better way, and and more effectively if we had plans to do that. Unfortunately, we didn't really have a plan on our table to guard the villages of the country, and that's why we really did not do well, and we could have done better.
Absolutely. I think you raised some very, very important issues, and I wanted to sort of tease them out one by one. One is that against the backdrop of what you laid out in the beginning of our conversation, the cultural barriers, the fear of COVID, and I would go so far as to say, in some ways, these are not necessarily specific to rural India. We experience them and continue to deal with them in urban India. And fear, as you say, panic, as you say, is very much part and parcel of a pandemic. But if I, were to put what you said to begin with and what you were saying about community health workers and self-help groups together, that in some ways, the key issue that we need to address first is in order to be able to address the challenge of barriers, panic, fear, one needs to be able to embed a COVID response in the community structure. And here we have in rural India the advantage of community organizations like self-help groups and ASHA workers that we can train up and work with to be able to build and bridge that trust. And I wanted to ask you to talk a little bit more. I mean, there are many things we should have done. And in fact, I couldn't agree with you more that the complacency and denial of COVID that sort of dominated the policy narrative from about September last year was done at our peril, and we are now suffering the consequences of this. But we are still in the midst of the second wave, and a lot can be done to go forward, as well as in terms of preparedness for the long term. So if you could tell us a little bit about what you think we need to do now on this. And then there are two other things that you brought up, which I'll come to next. But let's first talk about what we can do to strengthen the community engagement in COVID response, particularly the ASHA workers, the SHGs. You didn't mention local governments, but I'll push you a little bit on there to ask you to talk about whether you think panchayats can play a role as well.
Oh, absolutely. I forgot to mention, in fact, the villages are springs, basically. We don't harness the potential that creativity and innovations remain within the villages. And we, the urban folks, we keep on think that we can instill this into them. No, it's not. My understanding and experience says it's not. So, right now what we need to do is, in order to guard our villages, we need to sort of develop a sort of village health guard or village security team that would obviously have the village panchayat as the leader of the center, you rightly pointed out, but with the health-related and non-health related activists. And again, I emphasize that I consider the women self-help groups as a very important group, because, they don't represent a single individual. They represent multiple individuals who insinuate into every household, and any message, any endeavor, if you try to give it to the woman who is involved in the women self-help groups, goes up to the men in the family and to the child also. So I think I consider women, and they are very, very sort of motivated, as we felt. We have done many activities with them. But at the village level, we should have a village health guard team right now for door-to-door or informational screening of people who have got febrile, unwell being, telling them, number one, that getting COVID, the message that should go is getting COVID is not equivalent to getting death. Most of the people don't die with COVID. So, this is the message, because amount of fear, in media and everywhere, we keep on saying such bad things that everybody, and that's quite natural. I'm not, telling that's bad. Everybody who gets COVID starts thinking this, and this has gone deep into the villages. So that's one of the important sources of fear, but we need to erase that out in a composite way with the village panchayat, the ASHA, the self-help groups, and very importantly, informal sector healthcare worker. Because the informal sector healthcare worker is a sort of, imprecise curative care provider. They are modifiable. We have found that through our experiments, but there are many elements of that. Today is not the time to discuss that, but let me tell you that we tend to ignore them for no reason, out of a paranoid feeling. And me, let me tell you, I'm a sort of medical teacher, and our medical professionals have got a sort of feeling that they are our competitors, which they are not. They are basically an enriched healthcare workforce, which we can use in a complementary way to our healthcare delivery system in the remotest areas of the villages. So I consider them as candles in darkness, where no light exists. They are the only sources of, be in Sundarbans, be in Keonjhar, be in Mayurbhanj, be that, deforest areas of Chhattisgarh or whatever it is. You consider, there are many places. They are the only sources of care. 80% first point contact in many areas. Jishnu's research has shown, and I think CPR policy papers has also shown that. So I think, unfortunately, we in India, we pass through a tremendous no-do gap. That's also very important. Do you think that the policymakers don't know this? I strongly believe they know this. But we have got such prefixed ideas of not breaking our cognitive barriers. This is a very important barrier. We have got a prefixed idea, prefixed barrier, cognitive barrier, that they are all bad. We don't want to open our eyes and in a strategic, ambivalent attitude to them. So whenever policy discussions take place on informal healthcare workers, everybody would agree that after 7 decades of independence, India still have got at least 1 million of them all across the country. But we all know that they are illegal in terms of legality and everything. So legality, morality, and all these issues keeping apart, let me tell you, we also all know that they remain as the only sources of care where no care exists. And they keep on doing bad things, which you keep on highlighting.
Absolutely. And I think that because they're also embedded in the rural community, some of the trust issues that we talked about earlier would get. But Abhijit, I did want to move the conversation to vaccinations. We've had a lot of noise, I think, in our vaccination debates, both because of the policy bungle, but also because I think certain segments of urban India that have larger voice in our public debates as well have led us to, I think less about the complexity of unfolding a large-scale vaccination program on the one hand, and on the other, less about what is needed to provide information, knowledge, and potentially even awareness to vast swaths of the population on what are the pros and potential side effects, adverse effects of vaccinations. So wanted to hear a little bit from you against the backdrop of your experiences and many experiments that you are involved in scaling up vaccinations.
So I'll just start by telling that we need to put forth this message everywhere that vaccinate, because there was some hesitancy, and still now in some parts of the country, significant vaccine hesitancy exists among the rural folk. Not in West Bengal. West Bengal vaccine demand is what is there. But as I gather from friends and co-researchers, in parts of northern India, particularly, there is significant amount of vaccine hesitancy. So we need to devise a strategy to, put this message to people that vaccine is going to may not give you protection against an infection, because we are going to get more mutants of the virus, because it's an RNA virus, and by biology they are prone to mutations. So you may get infected. But even if you are infected the way I did, you are going to, pass out COVID infection with a smiling face with all confidence. In the country, it has been proven that people who are vaccinated and got COVID really did not have a bad outcome. Exceptions don't prove the rule. Okay. So that message, unfortunately, we had not been able to percolate down to the villages in their own language. So my language may not be the language that they would love to hear. If the Gaon Bura, or for example, the village panchayat, or the women self-help groups can be geared and provided the right understanding as a vehicle of awareness generation. Again, I come back to the deep village. So there are many parts of the country where there is a Gaon Bura, whom the village elder, whom many people would listen to, even the religious sect leaders in those areas. Any amount of vehicle that we can use, the panchayats, the informal health sector workers, the village self-help group women, if we, in a composite way, we provide them right knowledge that propagate this to your people, I'm sure vaccine hesitancy will be overcome. So once vaccine hesitancy you have overcome, it would be now our responsibility to convert them into a vaccine propagating and vaccine access generating team also. Because, and let me again emphasize, I just borrow this from the Supreme Court judge's mouth yesterday, that we need to be more rational. I don't want to use the irrational word. We need to be more rational and organized in our vaccine policy. And I believe that government should be the only primary provider of vaccine. That's a basic human right. And our country should be ready to meet that right. And vaccine should not be made, up for sale the way it's happening right now in many parts of the country. I mean, it's not a commodity the way rice or something like that. Even if it's a commodity, there should be an uppercut for vaccine price. Government need to do that right at the right earnest. Otherwise, we are going to land up again in a black marketing the way we had dealt with remdesivir or something like that. Vaccine cannot be handled like that. So either it's free, completely free, or if government does not do that, there has to be an upper price or something like procurement price. Why the corporate should not, give it at procurement price? Because they make so much dividend, even the corporate Medicare sector. So it should be their corporate responsibility. So they should not put something like 500 rupees more to take the vaccine to the people. So that's at the policy level. It should be provided by the government. But to make it available to the vast majority, 80% of Indians are in rural areas, 70% at least. So in order to, so that the vaccine reaches every Indian citizen with the right kind of prioritization, which the government is doing. I'm not demeaning their plans or prioritization. That's fair. We need to have a clear access policy where I think local agencies, community-based agencies like NGOs, community-based organizations, and panchayats, the self-help groups, and informal healthcare providers allow me to enjoy my fad with the informal sector's influence. We need to get into, and we need to figure out the socially marginalized and vulnerable segment who cannot really access your policy with that endeavor, like say physically disabled, the extreme elderly population, the extremely poor segment, the unorganized sector population. They are tremendous, very huge in number in this country. The migrant workers. We need to have a place where we really target them with the help of NGOs or even with the help of trade unions. I would love to leverage with, if that is possible, because they will have, at least can take us to them. The unorganized sector, informal sector workers like the hawkers, or for that matter, the street vendors, or all those, even the sex workers, large segment of people who have been, who are at tremendous risk because of the profession that they're engaged in. So all these, need to be broadly taken with a community savvy policy, rather than a policy which is instilled from preconceived ideas of addressing only the needs of the urban middle class. I'm sorry, I'm not against, I'm also an urban middle class, but our policies often addresses the urban middle class's needs, who can talk, who have got voice, who are heard, who are visible. So we need to think around the villages of India, and unless we we vaccinate the vast majority of rural Indians, I'm again emphasizing the COVID would reside in rural India and come back to us at its opportune moment. We all know that we have to live with COVID for the next couple of years, be it first wave, second wave, third wave, or whatever it is. It may not come in waves also, but it may come in spikes or short bursts in local areas also. In order to handle that, we need to vaccinate rural India with a clear understanding, and access has to be our motive. The marginalized, the vulnerable, we need to figure them out. The poor, we need to go to their doorstep to vaccinate, make them aware, make them make their understanding also clear, because often literacy and all these issues, customs and beliefs and all these issues will obviously come in. But I think we can overcome. We in India have done many good such ventures. Polio is an example where had been done very well, and there are many successes of vaccination in the country.
One of the factors that resulted in the success of polio, if I'm not wrong, is that its rollout actually was also embedded in a community participatory sort of approach, right? And I think that's one of the missing elements in our discourse on vaccination and COVID. So it sort of connects where you started, which, when the conversation we were having a little bit while earlier about the importance of community-based COVID treatment. If I were to interpret what you were saying from my perspective, am I correct in suggesting that perhaps what you're saying is that we need a community-based COVID vaccination approach as well? Yes. That community has to be at the heart of it.
Yes, absolutely. Absolutely.
Abhijit Chowdhury, thank you so much for giving us this really important insight into the realities of rural India, into what it will take to ensure that rural India gets access to quality treatment for COVID, and how to address the vaccine conundrum. Thank you for listening. You can follow us on Twitter at CPR_India and on our website www.cprindia.org.